So, right, sir, we'll be now formally starting it. So, I welcome you all in this GI Oncology, Decoding GI Oncology Webisode session. And today in 27th Webisode, that is 4th session of GB cancers. So we'll be winding off GB by having that discussion on metastatic or unresectable gallbladder cancers. And in faculty today, we have Dr. Sameer Khatri, who is a director and senior medical oncologist, Shanti Mukund Hospital. And sir has vast experience in treating GI hepatobiliary malignancies. And followed by a panel discussion. Sir will be a panelist also in that discussion with Dr. Mithun Chacko Jones, who is also senior medical oncologist in Jubilee Mission Medical College and Hospital, Thrissur, and Dr. Nagender, who is a senior medical oncologist in Medanta Hospital, Medicity. So I welcome you all, and I welcome all the students and the participants to have a very interactive and academic session. So all your questions, I request that you put up in the chat box so that we, in the course of panel discussion, take over with the questions also. So, sir, I welcome you for delivering a lecture on metastatic CHGB. So please share your screen.
Thank you, Shefali. Thank you for inviting me for this talk. आज थोड़ा टोन अच्छा नहीं होगा, बट वो बियर कर लेना मेरे से. So my slides are visible?
Yes, sir. Yes, sir.
Yes, sir.
Slides are visible?
Yes, sir. Yes, sir.
Okay. Just okay. So good evening, everybody. So today I will be talking about this metastatic carcinoma gallbladder. So I don't know what 3 topics you have studied up till now. So I will be to the point. Few slides will be there. There will be a practical slide and few practical issues which I also came to know now. So, and we can discuss that in the panel discussion, of course. So as we all know, the epidemiology and all, we must have already discussed. So this has a high incidence in South American countries, particularly Chile and Bolivia. And plus it is, as we all know, in certain parts of India, Pakistan, Japan, and Korea, its high incidence is there. So it is one of the commonest cancers in related mortality in women in northern and northeastern India, with a reported incidence as high as 10 per 1 lakh population in Delhi to as low as 2 in South India. So this is a drastic difference in the geography. In addition to this geography, there is also the age, race, gender differences related to it. So women are affected more, about 2 to 6 times more often than men, and the incidence steadily increases with the age. So it is more common in Caucasian than in the black. This is some of the tumor biology which is important to understand, is that the gallstones, this is the most important, the causative factor in the loss of P53, leading on to chronic inflammation and the downstream path phase. I will not go into the details of this. So why this metastasis? Why the metastatic carcinoma, they metastasize so early? So because, as we all know, the anatomy of gallbladder has a very thin wall and this narrow lamina propria with a single muscle layer. So this helps in penetrating the tumor cells. They penetrate very easily from this thin muscle layer, and it has access to the major lymphatics and vascular channels which are surrounding this thing. And so there is a tendency for early lymphatic, hematogenous, and direct spread to liver. As we all know, the histological carcinoma, most important is the adenocarcinoma, so followed by papillary and mucinous carcinoma, and now we are seeing the adenosquamous, squamous, and other carcinoma. So what constitute unresectable carcinoma gallbladder? So these are the way, typically the absolute contraindication for a radical resection. As we all know, the only curative hope for our patients is the radical resection, but these are the main absolute contraindication. We all know about these. Either the liver metastasis is there or the peritoneal metastasis is there. There is malignant ascites, or there is involvement of parotic or the lymph nodes like pericaval, superior mesenteric, and celiac artery lymph nodes. There is involvement of hepatodental ligament or encasement of or occlusion of major vessels like hepatic artery or portal vein by the tumor. So before coming on to the treatment of metastatic thing, so I don't know whether you have discussed with neoadjuvant therapy or not, but as we know that neoadjuvant surgical resection offers the only potential cure in this thing, in the carcinoma gallbladder. And since a large number of patients who present with locally advanced gallbladder cancer, they can be downstage by neoadjuvant therapy, and this increases the number of patients who can undergo an R0 resection. So another benefit of neoadjuvant therapy, as we all know, is that we can evaluate the biology of the disease, and those patients who respond well to the chemotherapy, they also have a better prognosis. And the best candidates for neoadjuvant therapy are those patients who are T3, T4 or the node positive, who are predisposed to high chances of recurrence by radical surgery. So this is the Tmh criteria which was given by Goel et al. And I hope you all know about this thing, or giving the neoadjuvant chemotherapy to these patients that are the T3, T4 patient node. N1 station nodes are there, that is N1. I hope you know about the hepatic artery involvement or hepatodental ligament lymph nodes are there, or retropancreatic or retroduodenal lymph nodes are there. Or there is a vascular involvement like T4 lesion with but less than 180 degree of involvement. Or when there is an incidental gallbladder cancer, the residual recurrent mass is there in GV fossa with liver bed involvement, and one disease is there, or there is involvement of bile duct causing obstructive jaundice. But obstructive jaundice type 1 or 2. So above. So what is the role of neoadjuvant chemotherapy, especially the gemcitabine cisplatin based chemotherapy or GEMOX based chemotherapy was used in various studies. Again, this Tmh criteria was used for this. These were the advanced borderline resectable gallbladder cancers, and they resulted in about 40% of patients. They resulted in a curative surgical resection. So remember this thing: about 1 in 3 patients will respond, will have a curative surgical. So 60% will not have any response. Also, the surgical response, the R0. So the initial studies, they have shown no benefit of. So there is a mixed results of neoadjuvant therapy. But since the usage of gemcitabine based or platinum based doublets, so the results have been better. This is one of the study in which response rate was about 50% with a clinical benefit ratio of about 70%, with about 40% of patients undergoing a curative intent resection. After a median follow-up of about 33 months, the median OS and event-free survival was 13 months and 8 months respectively. So those patients who underwent a curative R0 resection, they have definitely had a better overall survival as high as 49 months, versus those patients who did not respond and could not undergo a R0 resection. They had a overall survival of just 7 months, and event-free survival was 5 months in these patients, vis-a-vis those patients who had R0 resection. They had an event-free survival of 25 months. So definitely these patients should be offered neoadjuvant therapy as a only chance for cure. So now coming on to the treatment of advanced unresectable gallbladder cancer. So the clinical trials, they have very few clinical trials are there having gallbladder cancer as such. They are generally grouped with gallbladder cancer along with the bile duct cancer. So data is conflicting, data is combined data is there. So analysis of nearly 103 trials in biliary tract cancer suggests that gallbladder cancer, this may have a higher response rates to the chemotherapy, but they have a lower median survival compared to the bile duct. So for practical purposes, chemotherapy recommendations are similar for both gallbladder and bile duct cancers, and the reference regimen will be the gemcitabine and cisplatin. So the resection of metagenous metastasis is not justified, as I have already showed. So for unresectable or metastatic gallbladder cancer, palliative chemotherapy, it has shown to be have a better overall survival compared to best supportive care, as I will show. And most of the clinical experience and data are achieved from various small phase 2 studies. And there is a lot, it is largely that from these trials that clinical standards are adopted. And there are very few studies that enroll only gallbladder cancer. So I will show you a few studies of gallbladder cancer only patient, and hence the experience with chemotherapy for gallbladder cancer is generally from this biliary tract cancer patients. So patient with advanced disease should be considered for clinical trials wherever possible. So these are the list of drugs. Either we can use gemcitabine alone. This came in I think 1999, 2000, early results of gemcitabine. And I joined in 2002, 2003. There was this combination of gemcitabine, cisplatin, gemcitabine, oxaliplatin we were using. And there's gemcitabine, capecitabine combination, or basically gemcitabine combination with capecitabine or S1, or replacing cisplatin with carboplatin. They have been. Even there are results of Folfox or Capox as a first line. Or so this is the first thing. That's ABC02 trial. This is a phase 3 trial, basically a continuation of the ABC01 trial, which established this the role of cisplatin plus gemcitabine versus gemcitabine in biliary tract cancer. So ABC01 trial was basically the same trial, but when the benefits were there, it was ABC01 was a phase 2 trial. This was converted to this phase 3 trial to know the overall survival also. So basically 410 patients were randomized, 200 roughly in each arms. And so in this trial, the important thing which I also came to know now, and maybe we can discuss in that tumor this panel discussion why this is there. The dose of cisplatin was just 25 milligram per meter square, and gemcitabine 1000 milligram per meter square on day 1 and day 8 every 3 weeks. And this was in this go only that cisplatin was given first, followed by gemcitabine. And in gemcitabine alone arm, obviously it was 1000 milligram per meter square, day 1, 8, 15 every 4 weeks. And if patient did not have progression of disease after 12 weeks, then they continued with another 12 weeks of therapy. So this is very important, the dosage and all. I will have a small discussion about these dosage also. So these are the results. I will summarize these results. So the results of ABC02 trial was that the median overall survival was 11.7 months versus 8.1 months, and definitely advantage of cisplatin gemcitabine over gemcitabine alone, with a median progression-free survival again more 8 months versus 5 months, and tumor control rate 81 versus 71.8, and toxicity was roughly comparable in both the groups, with the exception of slightly higher rates of grade 3-4 neutropenia and slightly more nephrotoxicity. So if we see this ABC02 and 01 combination trial, so about 150 patients were of the gallbladder cancer, rest were the biliary tract cancer, and this benefit was across all the subgroups. Even those patients who had better PS, they responded much better, and then the PS2 maybe. This is the main thing, how to treat the patients who have PS2. And other thing also, the cisplatin gemcitabine, the combination arm did better. So this specific sequence of cisplatin, as I said, followed by gemcitabine, this seems to have an optimal preclinical testing. This study, I just saw this 1995 study, and so there was some preclinical study which is showing that in this way, when cisplatin followed by gemcitabine given, results are better. And to exploit this additive or synergistic effect, used a regimen that delivered both these agents at every dosing time point. The dose seems to be low, the 25 milligram, but the total is 50 milligram per meter square every 21 days. And the earlier attempts at increasing the dose intensity resulted in more dose delays and dose interruptions. Maybe this is the thing. Another two very important studies I will discuss from AIMS. So this was the first one was, again, both are by Dr. Atul Sharma, and this was the best supportive care compared with chemotherapy in unresectable cancer. So here this was a 3-arm study actually. So though the arm A was the best supportive care, arm B had 5FU and folinic acid and regimen, and arm C they had this Gemox chemotherapy, modified dosage of Gemox. In the sense the gemcitabine was 900 milligram on Mithun and Oncology 50 milligram day 1 day every for a maximum of 81 patients enrolled and about 25 patients in each arm. This was a phase 3 trial, and again look at the results. So this combination of modified Gemox, this had a better median overall survival, better PFS, and there was neoadjuvant chemotherapy was also given, so few patients had zero also. But the responses, PFS, OS, all were better with this. So this single center AIMS study of 81 patients reported that modified Gemox, this improved the PFS and OS, and median overall survival was respectively 4.5 months, 4.6 months, and nearly double 9.5 months with Gemox. And for this PFS was also better. So another study again by Dr. Atul Sharma from AIMS. This was that combination. This gemcitabine and oxaliplatin modified doses, same doses was compared, and with gemcitabine and cisplatin in again unresectable gallbladder cancer. This is a phase 3 trial. So again the dosage were the same for modified Gemox, and Gemcis was also the same dosage was there. This study showed that they had a similar overall response rate and median overall survival, but there was a slightly numerically the median overall survival was better 9 months versus 8.3 months with modified Gemox. There was more grade 3 for diarrhea, thrombocytopenia, and peripheral neuropathy grade 1, 2, as is expected with oxaliplatin and gemcitabine. Nephrotoxicity was definitely higher with gemcitabine and cisplatin combination. Now, can we substitute carboplatin for cisplatin? Again, studies have shown that carboplatin substituting for cisplatin reduces the non-hematological toxicity, but myelosuppression is very. So in a trial involving 20 patients of advanced gallbladder cancer, the responses were about 37%, with nearly 4 patients having a CR. Median overall survival was 11%. So roughly the same kind of results, but the grade 3-4 neutropenia was 20% and thrombocytopenia in 31%. This is the word. Another combination which has been tried in various studies is this combination of gemcitabine and capecitabine. 5FU, as we all know, have some activity in biliary tract. The combination of this was originally evaluated in 2 studies. Both studies showed that there was similar response rates and overall survival. And expansion of one of these studies showed to a larger cohort showed a promising activity. About 30% of patients responded and about 30 months of overall survival. 36% of patients were in this patient were the gallbladder cancer patient. But again, there was that from swab study group, and we showed that the response rate was anything that response is inferior survival about 7. So there are conflicting data about this combination of. But I personally think it's a very well tolerated combination, especially in those patients who we cannot give platinums or cisplatin. S1 is another oral product of 5FU. Response rates about 20-30% with an overall survival ranging from 9 to 12.5 months in various studies. Talk about that. So overall, if we talk about gem and capecitabine, this is a reasonable alternative to gem platinum-based first-line therapy, where cisplatin. So this is the study, the Fugabiti trial, in which it is a phase 3 Japanese study in which gemcitabine along with S1 was compared with gem and cisplatin. Median overall survival was better slightly, which was about 4 months.
Dr. Sameer, sorry to interrupt you. आपकी ना आवाज चली जाती है बीच-बीच में. So can you come closer to mic?
अच्छा, मैंने बोला था आज थोड़ी सी ना ट्यूनिंग की प्रॉब्लम है गले की वजह से. कोई नहीं. So I think up now you can hear me. Yeah. So overall response rates were about more in the both the thing were 30%. So adverse effects, if we talk about this thing, the S1 combination with gemcitabine, grade 2 or worse, fatigue, anorexia, nausea, vomiting, and mucositis and diarrhea were more frequent with gemcitabine and cisplatin, more or less the same thing, but more fatigue when all. So another combination is the Capox, and again it was compared with Gemox-based chemotherapy. Capox showed to be non-inferior to Gemox in at least one phase 3 randomized controlled trial, and there was no difference in responses, PFS, and so as I said, metastatic gallbladder cancer, this has a dismal prognosis. Sooner or later, most of the patients they progress, and hardly few options are there for the second line treatment. So there is no standard second line therapy after the failure of first line gemcitabine, and there are paucities of studies also. The regimen containing drugs in the second line, it should not be overlapping, as we all know. Only those patients who have good PS, they can undergo the second line therapy. So the patients who have this MSI high or MMR positive, so a high mutation burden, so this we can offer immunotherapy. So this was one of the studies of second line FOLFOX based chemotherapy, the ABC06 study, and it compared with the active symptom control for biliary tract cancer. This was a open label phase 3 study, and if we talk about this study, so definitely the patients who had FOLFOX, they did better with a hazard ratio of 0.69, and so this is one of the standard of care. And this is another study. It was published in 2021 in Lancet, and this is the drug liposomal irinotecan along with 5-FU and leucovorin, which was compared in 5-FU leucovorin, the NIFTY study. This is the phase 2B study. And again, this combination along with the liposomal irinotecan, this did better, and with the better overall survival. So this is an option available. So coming on to this novel agents or targeted therapies, the common mutation which we see in gallbladder cancer, these are the KRAS, about 3% to 38%, EGFR 9 to 12%. Even there are studies from India which are showing 80 to 90% IHC positivity, and BRAF about 0 to 33%. Important is this HER2 positivity, about 10% to 16%, and a few of Indian studies having even higher incidence have been reported. So a word about this anti-HER2 targeted therapy. So again, in a multi-center study from India only, upfront addition of trastuzumab to chemotherapy amplified significantly with no edit. Even in ESCO 2021, this was a study of disease control, 51% in those patients of gallbladder cancer who had amplified over expressing HER2. So other targeted agents, as I said, the EGFR and ligands are overexpressed in majority of cases. Erlotinib have been studied as a small molecule inhibitor of EGFR. Phase 2 study by Phillips et al. Study in this 42 patients were treated with erlotinib, and the response rate for 8%, PFS was 17% at 6 months, and a median overall survival was just 7.5. those patients who cannot tolerate maybe PS1 or 2, so they can be offered this a lot. So another phase 2 study evaluated lapatinib as a dual inhibitor of EGFR and HER2. However, it did not have much activity in the 17 patient of biliary tract. Angiogenesis also appears to be an important tumor growth for the tumor growth and metastasis. Sorafenib has been tried, but not good. I wanted to talk about this bevacizumab. Even I have tried in few of my patients, especially those patients who have ascites, malignant ascites. So I have shown they have been good. The bevacizumab combination with Gemox has done good for these. So this was a study in this with the efficacy of Gemox plus Bev was suggested in phase 2 trial of about 35 patients only. And this about 10 were gallbladder cancer. The dosage of bevacizumab was 10 milligram per kg day 1, day 15, followed by Gem and Ox. And the response rate, if we see, the PR was in about 40% of patients and about 22 patients with cholangiocarcinoma who were eligible for this. And the median PFS and overall survival duration was 7.6 months and 14.2 months respectively. So it has a good activity, especially as I said, in those patients who have peritoneal disease or a malignancy. Again, cetuximab and amivantamab all have been tried, but basically failed, not much activity. So in my last slide, so a word about immunotherapy. Obviously, the incidence about of MSI is 5% only. The Pembro has been studies and approved for those patients who have MMR positive or MSI high gallbladder cancer progressing on prior lines of chemotherapy. And nivolumab again has shown response in PD-L1 overexpressing biliary tract cancer. And there have been studies of this combination of Neoadjuvant with a durable responses, and those patients, especially on the second line therapy. So with this, I'd like to thank you all for the patient listening. Thank you.
Thank you so much, sir. I mean, with your general health right now, I mean, it's so good. You have covered almost everything. Now I'm thinking what to discuss in the panel discussion, actually. So not wasting much of the time. So I think there were 2 questions in the chat box and you have all answered already. So one was, what about the other biomarkers like HER2, NTRK to decide second line and beyond? Dr. Roshni has asked this. So I think they should be done, like you already mentioned. GB and hepatobiliary malignancies are known to have huge mutational burdens. So TMB, HER2, NTRK for that matter, FGFR2 now and IDH1, IDH2 should be included in the molecular markers. So what do you say, sir, about that NGS?
I didn't talk about NTRK. I don't know how I missed the slide. So NTRK definitely, few patients about 10-15% of patients, they may have NTRK, and with the drugs available, so maybe this is an option. HER2 is a good, often missed, so we hardly get it done.
Right.
I think we should get HER2. If we see the data, more and more data is from India only.
Right, sir.
So,
right.
And HER2, this positivity, this various data is there, and
Right.
conflicting data is there, as low as 10% to as high as 30-40% of patients having the expression, overexpression of HER2. So,
right, sir.
Interesting data, interesting studies from India. So,
right, sir. So, so I'll start the panel discussion without wasting time. So just give me 1 second to share my screen.
So, Dr. Shefali, I'll introduce you in the meantime.
Oh, okay. Take your time, please. Yeah.
So, thank you, Dr. Samir. Thank you for the nice discussion, and you have summed up everything very nicely for the students. And it's a devastating disease, we all know. So from now we'll continue on to panel discussion, and Dr. Shefali is doing the panel discussion. So Dr. Shefali hosts the Decoding GI Oncology program, and today she will also be moderating the panel discussion. And she is a senior consultant of medical oncology at Max Super Specialty Hospital, Saket, and she's a dear colleague. And we often see very gallbladder cancers. Many of them are operable, but many of them are not. And they will present with obstructive jaundice sometimes. So I guess she will also cover these aspects. So I welcome Dr. Shefali Sardana to host the panel discussion. Thank you.
Thank you, Dr. Nikhil. Thank you so much. Are my slides visible?
Yes, your this thing is visible. You can make it full screen presentation mode.
All right. Full screen. I think iPad में इसमें वो नहीं आ रहा है option. So
That's
anyways,
okay.
if it is visible, yeah. So carrying forward the discussion on metastatic GB, so we'll try to discuss a case scenario and try to discuss aspects related to this case as well as the other complications or the other things which pop up while handling a metastatic or unresectable GB. So this was a 48 years gentleman with no comorbidities, and he presented with obstructive jaundice. So he had an ultrasound report which showed that there is partially distended gallbladder with mild diffuse wall thickening and focal calcification within the fundal wall region, dilated biliary channels with abrupt termination of common hepatic duct at approximately 1 centimeter distal to hilar region. So, and he carried a report of liver function test which showed a total bilirubin of 11.4 with direct 8.6. Serum albumin was 3.2 and OTPT were fairly well. Mild derangement. So my question to you, sir, Dr. Sameer. So now how do we approach now in this patient, and what other investigations are required? Do we really evaluate the biliary system, the obstruction level, and to decide for what to do next? Sir, your voice is not audible.
Can you hear me now?
Yes, sir. Yes, sir. Please. जी sir. Yeah.
Just एक slide पहले ले लो. Just previous slide.
Yeah. Yes, sir. This is the previous one.
Yeah. So as I can see, so at least CT scan, triple phase CT, or maybe a CT scan is required, or MRCP is required. At least that is required for the see for the any metastasis or not. And if we see if the operability and all, so though there is an obstructive jaundice is there, nodal status is not known. So these factors need to be known before going in for any.
Right, sir. Right, sir. So, Dr. Mithun, do you directly do a PET CT in such cases, or do you proceed with like triple phase CT first, followed by MRCP, and so on and so forth?
No, I usually proceed with the triple phase CT first, then MRCP, not PET CT upstairs. Definitely, I think triple phase CTs for the local, we'll have to see whether it's surgically resectable or not. PET CT is more for assessing the metastatic disease. So I do prefer to go ahead with a triple phase CT first, then reassess after the CT scan.
Right.
Regarding this thing also, whenever we get the PET scan done, I also get the PET scan first. So triple phase incorporated there only. So before CT PET, so triple phase CT with PET scan. So it saves time also. And MRCP, because the patient
sir, got your
will
point.
Require Ercp or Ptbd or anything. So
sir.
Yeah.
So got your point. So most of the time, sir, what we do is to do a triple phase CT first, because if the patient is already metastasizing to liver in a triple phase CT, or for that matter, so the mass seems unresectable, so we may get away with simply doing a HRCT and not doing a PET CT for that matter. So most of the time intent may be decided straightforward on a triple phase CT whole abdomen, and followed by the further evaluation. But I got your point. So it's worth that if the facility is available, resource is not a constraint, so PET CT can be done in such a situation. So this patient actually got a MRCP, and it showed pathological gallbladder with poorly distended lumen and diffuse wall thickening without obvious calculi. So there was an ill-defined soft tissue thickening contiguously extending to involve the proximal extrahepatic bile ducts, the biliary confluence, the right main duct with resulting intrahepatic ductal dilatation, separated right anterior, right posterior, and left main ducts. There was mild upper abdominal lymphadenopathy. So possibility of primary GB/biliary neoplastic process is likely, and HPE correlation would be necessary. So that was the MRCP report. So Dr. Nagender, so I would like to ask you what next? So considering that this is a locally advanced disease, systems are separated, so how would you proceed? Would you try to do a biliary drainage first, like Ptbd and Ercp stenting? And how do you choose about which of the process to be done? So what is the preference modality in what you choose?
Right. So always we are discussing this type of patients in multidisciplinary tumor board, in which our hepatology colleagues will take their opinion, which modality of treatment by which we can bring the bilirubin to a near normal range, so that we can offer this patient treatment. Simultaneously, we will make sure that the tissue diagnosis is established. The standard oncological principle of diagnostic investigation and staging investigation have to be followed. And once the tissue diagnosis is established, along with that, if the bilirubin comes down to less than 3, discussing the patient's preference, and we can take the case forward.
Right. So, sir, Dr. Sameer, so what is your experience regarding Ptbd versus Ercp stenting, one preferred over the other, and how do we choose which way to go? Like this patient also had obstructive jaundice, but all of the 3 draining systems were separated. So how does it make a difference?
So basically, this is, I think, type 3 type of a 3A type of a blockage, or maybe. So the differentiating between Ptbd, you should know that while doing Ptbd, we can internalize that very easily. So it takes about half an hour or so, cath lab, very easily Ptbd, and then stent we can do percutaneously also. So as I was studying for this topic, I studied this thing also, the Ptbd versus Ercp stenting. Those patients who are not resectable, and we have decided that the intent of treatment is palliation. So Ptbd versus stenting, there is one study is there, few patients were there. So they found out that Ptbd was better as compared to Ercp and stenting. And of course, this the success rate was higher of Ptbd. Ptbd is actually very, very easy if it is amenable to Ptbd. So Ercp at times it's very difficult to see the that papilla. So because of the edema, cholangitis associated, but Ptbd, the dilated this biliary radicals, we easily see. Even I at times think I can also do it. So, and there was a study was there in which 90% success was there with Ptbd versus what with Ercp stenting. And but in this study, obviously in Ercp and stenting, as I have seen, more and more cholangitis is there. So complication cholangitis, and at times we lose the patient also with cholangitis, because the multiple attempts are there for papillotomy, that's finding the papilla, then doing the thing. So what I personally think, and maybe my intervention radiologist is very good at it. So what I personally think, those who are amenable for Ptbd, they should undergo Ptbd. Very easy, half an hour job.
Right.
And even now they are doing 2 drainage pipes also, 2, or if they have 2 separate systems out there, 2 drainage pipes. Another, even in the study, they said even if we drain about 40% of liver, it is also sufficient for the personally. I think absolutely is better. It's my experience.
Right, sir. Right, sir. So, so there is a study you rightly mentioned, which has compared Ptbd versus Ercp. Though there were certain limitations in the study, but it clearly showed that in the tumors which are more proximal to the hilar area, or where the systems are separated actually, so the complication rate with Ercp and stenting is higher. So Ptbd is preferred in those areas, plus stent related complications, the blockages, they were really not bothersome. However, the infection rate and the complication rate was certainly higher in Ercp and stenting as compared to Ptbd. The one limitation with Ptbd is actually the external drainage, which sometimes bothers the patient. Yeah, so then this patient, after evaluation with triple phase and other MRCP things, so he underwent a PET CT, which showed a FDG-avid gallbladder wall diffuse thickening with FDG-avid soft tissue thickening encasing common hepatic duct, causing IHPR dilatation with regional lymphadenopathy. Few 3 to 4 in number sub-centimetric non-FDG-avid subhepatic surface nodules present. Query significance, whether they were disease or not, it was not clear on PET. And other routine investigations were normal. So, Dr. Mithun, so what should be our next approach? So, considering 3 to 4 nodules in the, peritoneal surface in the hepatic area, should we consider that patient as, say, totally a palliative intent, or, you should proceed with the staging lab to decide the intent in such cases? So how do you take it? So in your experience, how many of them presenting in this situation turn out to be metastatic? And how should we decide the intent of treatment in such cases?
Yeah, the best option would be to discuss in tumor board. Usually we discuss in the tumor board, and when we come into a topic, so decide accordingly. And the best part will be to go ahead with the staging laparoscopy to see the proper staging of the disease, because otherwise we will be branding the patient as a stage 4 disease and the whole treatment will be palliative intent. So first approach will be to decrease the bilirubin level. Best option would be Ptbd in such scenario.
Right.
And see for the resectability. If it's not resectable, then go ahead with the biopsy and go ahead with the next line of chemotherapy.
Right. Right. So, Dr. Nagender, what do you follow in your institute? So, do you do staging lab in such patients as a routine where there is not a clear evidence of having a metastatic disease on PET, or but has a locally advanced disease, to decide for neoadjuvant intent versus a palliative intent? So, how do you proceed?
This is a very clinical problem which we also face many times. The staging is very, very important. The whole of the intent of treatment depends on the stage. So we always open up the discussion into board, and we'll always tell the patient that in this type of scenario, staging laparoscopy will give us conclusively whether what is the stage of the cancer, we can treat you better. But sometimes what we have seen is the patient or patient relatives, they will deny for any surgical intervention or any laparoscopy. In that case, we are stuck and we have to label this patient as MX, and we have to take action accordingly. We cannot label them M1 based only on radiological evidence. We have to have a confirmed tissue diagnosis from the metastatic site, or we will take it as MX and we'll go ahead with the approach. And after suppose 3 cycles, we will do the rescanning. We'll compare the pre-treatment scan with the post-treatment scan, and we'll take the case forward.
Right. So, Dr. Nikhil, you are there. So, considering this scenario, so how do you approach this patient? Do you straightforward say that, okay, this is such a locally advanced disease with such extension, so would a staging lab will help in this case, or should we straightforward label the intent as palliative in this situation? So recently we have come across quite a couple of cases like this presentation.
So it all would depend, Dr. Shefali, on what is the resectability. So generally Cagb with obstructive jaundice are not operable. Literature says around 50% of them might be operable. I'm talking about non-metastatic patients. Generally, in our experience, the resectability rate is much lower. Right. Now, we try and do certain things in these patients. We will drain them, we'll give them neoadjuvant treatment, and we'll hope and pray that they come to the table, but they generally do not come to the table. Right. So my approach would be a balance of these two. If I think that there is a good probability, or at least not good, reasonable probability of these patients being operable. So if there is only obstructive jaundice without any major vascular encasement, right hepatic artery is okay, but apart from that, if there is any major vascular encasement, I would label them unresectable and not do a staging laparoscopy. we would upfront say that this patient is unlikely to be operable, go ahead with palliative treatment. But if there is a good possibility that this patient might be operable at some point of time, then before giving neoadjuvant and taking some other things, like sometimes we'll do volume optimizing strategies on liver, like we'll have to do PV and all those things. So before doing any such things, we will do a staging lab to rule out a metastatic disease.
Right. So having said that, the message clearly goes that it's a multidisciplinary approach. So before deciding the intent as a single-handed, so we should discuss the case with our surgeons. So understand whether it is clearly unresectable or it has potential of resectability, so that we can properly stage the patient and then proceed forward. So then this patient underwent actually staging laparoscopy, and it showed a multiple metastatic disease in omentoperitoneal region, and biopsy from the nodule was taken and it was closed. So biopsy showed poorly differentiated adenocarcinoma. Patient underwent Ptbd and bilirubin came down to 3.8 on day 5. And plan was to start the palliative chemotherapy. So, Dr. Sameer, sir, question to you. So we know that there is no first line standard of care actually. There have been retrospective studies. You clearly mentioned various trials. So how do you decide whether to give Gemcis in this patient or Folfox? Does bilirubin level guide us? Does the trend of decreasing bilirubin guide us? Which regimen to choose and in what modifications? So how do you decide, sir?
Simple thing, if the patient does not have any jaundice at presentation, metastatic disease, no jaundice. So then there is no question. I always start with cisplatin and gemcitabine. So and if there is a jaundice is there, like in this patient who is responding to that, so personally, I will prefer Folfox in such kind of.
Right, sir.
I will avoid gemcitabine.
Okay, sir. So, Dr. Mithun, what is your institutional protocol in such kind of patient who present with obstructive jaundice, has a good biliary drainage in the form of Ptbd or Ercp stenting, and now the bilirubin is coming down. However, it's day 5 or day 6, the bilirubin is still more than 3. So, how do you decide about it? Dr. Mithun, you are not audible.
Yeah.
Yes.
I think as Dr. Sameer sir has told, if there is hyperbilirubinemia, definitely Folfox. If it's coming down to less than 2 and all, I go with gemcitabine cisplatin. That will be the first line of treatment, first line of chemotherapy in GB, definitely.
Right. And what dose modification in bilirubin 2 you do for gemcitabine?
No, in 2 I don't do any modification. If it's more than 2, I usually go ahead with Folfox.
All right. Okay. So what we follow here is so till bilirubin 3, and what literature also says that we do the gemcitabine modifications to 800 milligram per meter square, and once it settles down to say 1 or near about that, so we increase to the full dose. Otherwise, more than 3, we also prefer Folfox in such scenarios. So, Dr. Nagender, so any other markers?
Shefali, what dose of cisplatin you use?
Sir, 800 milligrams per meter square. Cisplatin. Cisplatin, sir, we generally use 75 milligram per meter square.
But studies are showing 25 is also.
So, sir, there are 2 studies. I got your point. So, one study mentioned that it was cisplatin 25 milligram per meter square every week for 24 weeks along with gem day 1 and day 8. And other study which you mentioned, ABC02. So, it used 8 cycles. Generally, we do the 6 cycles and increase the dose of cisplatin in. So,
one thing I also came to know, giving it has more synergistic activity. I don't know. Maybe I will start using it.
Right, sir. Right.
I'm in doing that. So
how are you giving on day 1? 75 milligram per meter square divided dose. Day 1, day 2.
No, divided into day 1 and day 2 actually.
Okay, yeah, same. Cisplatin day 1, day 2.
Yeah, since 2002 or 2003, I was in Rajiv Gandhi at that time. We are giving gemcitabine. We were giving gemcitabine 1250 milligram per meter square day 1, day 8, and cisplatin 75 milligram over 2 days. Then we reduced the dose of gemcitabine, but cisplatin we continued for 75 milligram. Since now nearly 20 years. Nearly 20 years.
Right, sir. Right.
And
So,
one more thing
I
I just want to add. Before using gemcitabine cisplatin at this doses, we always do a DTPA GFR to make sure that patients are eligible for cisplatin. Before that, we will not directly go for this. If sometimes patients, not only the bilirubin which decides, it's the renal function also which throws light whether we can use cisplatin. And otherwise, if cisplatin patients are ineligible, obviously we are left with either you can use carboplatin at modified AUC dosage, or FOLFOX for that matter will solve the case.
Absolutely right. Absolutely. So DTPA renogram and over and above that, 2D echo is also very important in elderly age group too, because cisplatin requires too much of fluid also along with it. So totally agree with you. So Dr. Nagender, any other biomarkers or molecular markers you send at the first go once the intent is decided as palliative, or you wait once the first line works for the patient or not? So how do you decide about it, when to send the molecular marker status?
Right. So upfront, whenever the tissue diagnosis is established, we will send the standard test, like we will do PD-L1, MSI, and HER2 testing upfront, rather than doing an angio. If the patients are affordable and if they understand how the science is unfolding, especially NGS and all, so if they understand that, we will go for that. But rarely any patient will be opting for that. But if at all any affluent patient who can understand the biology, how it's going to be helpful in sequencing the treatment in future, we can do. Otherwise, majority times, these are the three things which we'll do: PD-L1, MSI, and HER2 upfront.
Right, absolutely right. So we have also a couple of patients where we got HER2 positive or the other molecular markers in NGS. I'm sure, sir, you would also have the similar experience. So, I mean, what molecular markers do you select specifically? PD-L1, MSI, HER2, NTRK, or do you send a broad-based panel?
Clearly said, this is the thing we are doing.
All right, sir. Okay. So this patient received 4 cycles of chemo with...
at least.
Right, sir. Right.
Yeah.
So this patient received 4 cycles of chemo with GemCis protocol with the dose modification in the first cycle for Gem. And after first cycle, after 4 cycles, sorry, it's a misprint. So 4 cycles, PET-CT showed a progressive disease in liver. So the question is, I mean, how do we decide next line again? So should we jump forward to immunotherapy, or should we decide on the basis of PD-L1 positivity in the MMR proficient patients, or is there any other way you choose directly FOLFOX or any other for that matter? So, and one more question, sir. So is there a role of maintenance GEM in patients who are responding actually? So any of you can take this question.
Maintenance का मैं बोलूँगा.
Right, sir.
Because I had one patient, like you said, patient received 6 cycles, and after that, unfortunately, he had a seizure. So went to a neurosurgeon. There was a solitary lesion was there. Operated, adenocarcinoma, IHC proven for gallbladder. Again, continued with gemcitabine cisplatin. This is the only patient I can remember who is still alive after 8 to 10 years also. But in this patient, it was a metastatic disease to start with. But this patient received nearly gemcitabine for 1 year or so.
Right.
Maintenance, maybe, and this is very old patient of mine.
Right, right. So, Dr. Mithun, what do you say?
Yeah.
I mean, is there
so maybe there is a role is there, but no. But studies say not more than 8 weeks, 4 to 8 weeks. No, 4 weeks first.
Right, sir. Right, sir.
Then 4 weeks more, not more than that.
Right. Right. So, Dr. Mithun, so do you practice their maintenance GEM in a responding patient?
We can't find any data. Actually, there won't be any data for maintenance gemcitabine, single agent gemcitabine post GemCis. But I think what I usually practice is that in patients who have very good response and very good tolerance, I prefer to give gem maintenance. The patient is willing.
Right.
That's
right. And
what is the usual practice I am doing.
Right.
So the answer lies in that historically we know that gallbladder cancer in advanced stages carries dismal prognosis. We all know the gallbladder cancer is a highly lethal cancer, and it carries a reputation of poor prognosis on the whole by and large. So if the patient is responding to the treatment, like we have given as per guidelines are just to guide. If the patient is responding to GemCis after 4 cycles, and the volume is like there's no tolerance issues, as Dr. Mithun mentioned, the patient's tolerance is excellent in a good performance status. There is no organ reserve issues. This type of patients, I will be going for gemcitabine because first it is very, very important in this cancer, because by and large, we know that 1 year survival is less than less than 5%. Talking about 5 years survival in metastatic gallbladder cancer is a joke in clinical practice, isn't it? So first hit on this cancer is very, very important, because majority of patients are not fit for second or third lines. Their performance status deteriorates. They will have toxicities. It is very, very difficult to give the standard doses in the correct sequence with the intensity maintained. So that's why first line of treatment is very, very important. By this, we can enlarge or can extend the overall survival of patients. Ultimately, in stage 4 cancer of gallbladder, per se, we want these patients to live longer. As a medical oncologist, what we want is we want to keep this patient as good as possible for as long as possible. And how we can do that? By correct sequencing of the agents. And if we can give the first shot best.
Right. Completely agree with you.
There is a way by which we can increase the oral.
Right. So agree with you. So we also practice the same thing in exceptionally well responding patients who do not show the sign of any toxicity or who are tolerating it well. We also practice maintenance gem in those patients. So what about the second line and so on and so forth? So like the ESCO NIFTY study mentioned use of liposomal irinotecan based treatment with 5-FU-leucovorin or FOLFOX. So how do you choose? Dr. Nagender, followed by Dr. Mithun, and then sir. So how do you choose the second line now?
So if we see historically how the disease treatment evolved over a period of time, there are basically 4 drugs by which we can extend the survival of the patient, which are having a solid evidence. We know the gemcitabine, platinum, which can be like oxaliplatin or cisplatin, 5-FU or capecitabine. These are the standard drugs by which we can extend the survival. Other drugs, like if you told that NIFTY study in which liposomal irinotecan is used, but that drug is having a phase 2 data. There is no phase 3 data to back it up, right? And first of all, this is not available across the globe in all the countries. So as far as chemotherapy is concerned, these are the 4 viable options. And fifth one is that S1, which also is combined along with the standard backbone arm of gemcitabine or Gemox. So these are the agents by which we can extend the survival. Other thing is at molecular level, we can use PD-L1, MSI, HER2 testing, NGS, by which we can use the other agents. But as far as chemotherapy is concerned, the solid evidence is for these 4 drugs. Liposomal irinotecan is yet to come to the pen of the doctors because we are not having hands-on experience. We have not used it. It's only in the academic level or a center where research is going on. Second line treatment, always option of clinical trial have to be justified. If the patients can afford that and if they are having access to that, go ahead with clinical trial. Otherwise, I'll be happy to use Capox or FOLFOX depending on the patient's fitness and performance status.
Right. So, sir, in the second or say third line, so do you really use PD-L1 as a biomarker, say after the second line, or do you give nivolumab or pembrolizumab for that matter? Or I mean, what value of PD-L1 as a biomarker do you use to select immunotherapy for your patients? We know that response rates are less and there is no clear-cut level 1 evidence to use immuno in these patients. So how do you proceed in third line?
Third line,
so
third line, very few patients are there surviving for so long. So I will tell you about second line first. So my preference always is first line cisgem followed by FOLFOX as a second line. And if the patient is responding to FOLFOX, I have a good many patients now who are on maintenance just capecitabine only now, who have responded to 6 cycles of FOLFOX. Maybe 5 to 10 patients are there on capecitabine for maybe up now 8 months. One is on capecitabine for nearly 2 years now. Maintenance capecitabine. So these are also very good drugs. Capecitabine, FOLFOX. And another is the bevacizumab, very underused, especially those patients who have ascites. I have seen very good results for those patients who have malignant ascites. Now coming on to the role of IO. I have never used actually in this patient. This trastuzumab I have used in one patient. Again, not a very good response was there. I don't know. IO, I have never used it. PD-L1, in fact, never came out to be positive in any of my patients.
Right.
NGS,
So,
definitely a role of NGS is there.
Yeah.
Patient can do. NGS is there. But I see first line GEMS, second line FOLFOX, maintenance capecitabine if patient have responded.
Right. So our experience here in Max is, I mean, I asked Dr. Sandeep Batra also. So, and couple of my patients who were HER2 positive, they really responded well to trastuzumab. But however, when they progressed, none of them responded to pertuzumab or TDM1 for that matter. So I don't know why, but they never responded to any other agent except for trastuzumab along with chemotherapy. So what is your take on it, sir?
Yeah, definitely. But that's what I was saying. The initially response rates may be there, but that's a very short-lived response is there. 4 months, 5 months, and not like breast cancer. You cannot expect it like breast cancer or anything. Even not like a gastric cancer also. Not like gastric also.
Absolutely. So, Dr. Mithun and Dr. Nagender, so you are also using trastuzumab or any other anti-HER2 therapy in your GB cancer patients who are HER2 positive?
Only trastuzumab, but not prolonged responses, not sustained response like what we are seeing in breast. Very short-term responses.
Okay.
And another thing I have to just mention is that patient has not responded to first line chemotherapy. So the chance of responding to the second line is also less. So I think if the patient is affordable, go for NGS in such a scenario. I will be going ahead with Capox or FOLFOX, but at the same time, I will be asking the patient to get an NGS done, and if any targetable mutation, go ahead with the treatment, because very likely the patient is not going to respond to the second line as well. I don't know. That's what we usually see. First line no response, second line also very less chance of response.
Right. So there is one question in chat box. Dr. Nikhil, you can take it up. Is there any role for surgery in a stage 4 Cagb showing good response after the first line chemo, then to continue or maintenance 2 to 4 line chemo or immunos?
Just a sec. Somebody is speaking. Okay. So, Dr. Shefali, generally speaking, broadly speaking, no role for surgery. Right. In an exceptional case where there was an exceptional response, and we also would have given a time trial to that patient and the disease doesn't come back. So in a very, very rare circumstance, we might consider surgery. In our entire career, we have done these kind of things once or twice, not more than that. So a simple answer is no, but yes, in a very, very exceptional circumstance, we might consider.
Right. And one more question you have already answered, but however, so if you can briefly mention on a surgical part, there are 2 opinions regarding port site excision. So in T1, T2 gallbladder cancer. So can you give some idea regarding the same?
So generally, I mean, obviously there is some trial which initially suggested that we do, but now most of the trials suggest that we shouldn't do. So what we generally do, I'll tell you, what we do is that if the gallbladder has been taken out through a port, not in bag, right? So we will consider some implantation would have occurred there, and we will resect that port. Otherwise, generally, we do not resect port as routine. And we also have seen some port site metastasis, isolated port site metastasis after some time, and we will like sometimes go and resect those also. But generally, routinely, when we are operating an incidental gallbladder cancer, we routinely do not resect ports.
Right. So I hope we have answered all questions. So since there are no more questions, should we sum up? Yeah, I think Dr. Nikhil, should we sum up?
Yeah, please. If you're done with, you've taken all the questions in the chat box, right?
One thing I want to add, Dr. Shefali, just one anecdotal experience I want to share. That regarding NGS, it's not only that BRAF, NTRK, and this one patient has sent NGS in gallbladder metastatic setting, and we have got ALK positivity in that. And this patient has started on crizotinib, and 15 months patient have responded to the oral targeted treatment. So we should always be optimistic. We should encourage patients to go for NGS testing. We never know what report will come out, is it? Because they are testing at a molecular level. So that patient responded very well for 15 months in second line setting. after NGS, and the patient has lived for 3 years and beyond. So,
correct. So my patient also responded for 9 months on crizotinib. Yeah. So and she was in a good general health because of chemo for 9 months, and she could tolerate the third line and beyond also after that. I used crizotinib in actually third line post Gemcis and Capox failure. Yeah.
Right. So this is the beauty of
so
NGS.
I totally agree with you. So NGS is a good option in patients who can actually afford or who can afford the further lines of targeted therapies. So actually it is good. So I thank you all for a wonderful discussion. So metastatic GB, I mean, I didn't think that, okay, this could go that 40 minutes after Dr. Sameer's talk. So wonderful discussion. I thank you all for participating. Thank you. And see you in the next episode. So Dr. Nikhil, what are we planning next?
Rectal cancer, Dr. Shefali.
All right, Ji. So we see you on first Wednesday of next month with a very interesting discussions on rectal cancer. So starting from the basics till the metastatic setting. So thank you so much. Yeah.
Thank you, Dr. Shefali. Thank you all panelists. Thanks for taking part in the discussion and educating us and everybody around. See you next time. Thank you very much.
Thank you.
Thank you very much
Good
for the
night.
opportunity.
Thank you.
Bye-bye.
Yeah.